Hi, good morning. My name is Wesley Wright. I'm a USF Internal Medicine PGY3. Today I'm going to go through a little bit of gallbladder POCUS. So a brief overview of what we're going to go through this morning. So quickly going to go through some gallbladder anatomy, as well as a brief overview of gallbladder POCUS, as well as defining normal, which is very important before we look at pathology. Then we're going to look at some common gallbladder pathology, and then going to go through some cases, and then a little bit of questions too. So here we have the gallbladder. So we can see an illustration to the left here. So we have the fundus, the body, the neck. Running on down, we have the cystic duct, which then connects with the hepatic duct, which then comes together for the common bile duct. To the right of our screen, we see an ultrasound image. So it's very important as we go through here to keep the same sort of orientation as well as our systematic review of an ultrasound image. And so what we want to do is figure out exactly what kind of probe we have first, and then go through what kind of orientation we have, as well as looking at all structures. Even though our focus is on gallbladder, we want to make sure that we see and identify all images within the image itself. So here we see we have a curvilinear probe, which I'll go through on our next slide as well. We are in the medical orientation. We have our marker to the left of the screen. Then as we go down, we start to see some structures. So to the left, we have an isochoic structure. This is representing our liver. And then we see an anechoic structure to the right of the screen. This is our gallbladder. So we see like our illustration to the left, we see the fundus, body, neck, and then as we go through, we can see some important structures here. So we see the portal vein, we see the hepatic artery, and the CBD, so the common bile duct. So this represents our portal triad. This is also known as the Mickey Mouse sign, whenever you can see that. So the basics of POCUS when looking at the gallbladder. So our probe that we're going to use. So as you see down to the bottom right here, we have our probes. So the curvilinear probe is one that's often used. It's good for looking at deeper structures, has a lower frequency, as well as the phase array probe. They can both be used when looking at the gallbladder. Techniques for viewing. So there's two common techniques for viewing the gallbladder. There's something called the subcostal sweep. So you have the probe in the sagittal orientation with the probe indicator towards the patient's head. You have the patient take a deep breath, and then you sweep the probe inferior and laterally along the right subcostal margin. And then another approach is the X-7 approach, where you find the xiphoid process and then move laterally about 7 centimeters to the right and place the probe perpendicular to the skin in between the ribs. And then most of the time you'll find the gallbladder right there, posterior to the liver, immediately beneath the probe. Other ways that you can help to get your gallbladder into view. So you can use some techniques called fanning. So this is whenever your probe is in a horizontal rotation, you can move the probe up and down, or you can use something called rocking, which is moving the probe left and right, which may help to pull the gallbladder into view. So what is the utility of POCUS for gallbladder? So generally, this is considered the best diagnostic test to confirm gallbladder disease. It's a non-invasive test. It's a very quick test to perform with a large diagnostic yield. It's about 84% has 84% sensitivity, 99% specificity for detecting gallstones, and it doesn't involve ionizing radiation like CT scans. So before we look at some pathology, it's important to define normal. So the gallbladder is typically a pear-shaped anechoic structure with a hyperechoic wall, typically around 7 to 10 centimeters in length, typically less than 4 centimeters in diameter. The wall is usually less than 3 millimeters. And then you can see here in our image, as the gallbladder comes into view in the beginning of the image here and at the end, you can see there's a structure, a linear structure that connects the gallbladder to the portal triad. And this is the main lobar fissure. It's really great whenever you can see all these structures. You see the gallbladder coming in, you see the MLF, and then you see the portal triad as well coming into view. So this is that Mickey Mouse sign that I was talking about on a previous slide. And then ideally, for best image quality, you want the patient fasting for at least 6 to 8 hours prior to imaging. This is because you may have the gallbladder contracted and you might not have a great image when viewing shortly after eating. So a few pathologies we're going to go through today. We're going to look at some gallstones, acute cholecystitis, gallbladder polyps, adenomyomatosis, as well as gallbladder carcinoma. So cholelithiasis occurs within 10% of the population. It's a predominance for women of 2 to 1. And the prevalence increases with age. It may be symptomatic in only 25% of the patients though. So your typical presentation that you're going to see when somebody comes in to the clinic or the ER, they're going to complain of some right upper quadrant or epigastric pain that's shortly after eating a fatty rich meal. This is something called biliary colic. The pathology of these stones are typically crystal, mixed, or pigmented, where mixed is the most common. There are many complications of gallstones. Those listed here are biliary colic, cholecystitis, acute cholangitis, pancreatitis, obstructive jaundice, risk of malignancy, and many, many more, as we'll go through some. So here in the image, we see some gallstones on ultrasound. So gallstones themselves are highly reflective echogenic focus within the gallbladder lumen. You'll see prominent posterior acoustic shadowing, regardless of what the stone is composed of. You may see something called the rolling stone sign. So since the gallstones are freely moving within the gallbladder, you may be able to change the patient's position and see that they're moving. This may help you from differentiating a stone from a polyp. You may also see something called a twinkle artifact. So for small stones, you can look at it with a color Doppler, and this may actually be more sensitive for detecting small stones than looking for that posterior acoustic shadowing. And like I said previously, ultrasound is 84% sensitive and 99% specific for detecting gallstones. So I'll go through this image here. So first, it's important to go through our orientation. So right here, it looks like we're using a phased array probe. As well, we're in the medical orientation as our marker is to the left of the screen. We are seeing, you want to comment on the quality of the film. So it looks like we may have some extra gain in this film as our liver, seen on the left hand side of the screen, is a little bit hyperechoic. As well here, I think otherwise we may be a little bit deep as far as looking for the gallbladder. This could be a little bit less depth here. Otherwise, I believe it's a pretty good image. As you see here, we do see a hyperechoic structure lining an anechoic structure. So we do see the gallbladder to the right of the screen. As well, to the left, we have an anechoic structure signifying the portal vein. And then we see a rounded hyperechoic structure within the wall of the gallbladder. This is our stone. And as you see, we have some shadowing coming beyond the stone itself there. So this is actually a video clip. So let me see it. Oh, I don't know if I'm going to be able to get it going here, but this is a video clip where you can also see the MLF here coming into view, and you can see the portal triad. So acute, well, this might, there we go. So there we can see the MLF coming into view, and then you see the stone with the shadowing present. So our next topic here, acute cholecystitis. So this is acute inflammation of the gallbladder. It's the most common cause of acute right upper quadrant pain. Cholelithiasis is responsible for 90 to 95% of these cases, where the remainder is acalculous cholecystitis. Typical presentation of right upper quadrant pain with radiation to the shoulder that persists. Unlike biliary colic, this may be biliary colic kind of comes and goes, whereas you may see with acute cholecystitis that the patient's having these symptoms for 6 to 8 hours. The pathology of acute calculous cholecystitis. So we have a gallstone that obstructs the gallbladder neck or the cystic duct. We have inflammation from chemical injury of the mucosa, production of mucus, which leads to an increased luminal pressure and distension, which leads to restriction of blood flow to the gallbladder wall, causing increased wall thickness from edema and inflammatory changes. For acalculous cholecystitis, this is typically a very ill patient or an injured patient where there may be some perfusion of the gallbladder that is disrupted and causes bile stasis, which leads to injury and inflammation. And that continued ischemic reperfusion injury is a very pathogenic feature of acalculous cholecystitis. So here we have a couple of ultrasound images. So the most sensitive finding is the presence of gallstones in combination with the sonographic Murphy sign. So this is about 87% sensitive and 82% specific for acute cholecystitis. You will see some gallbladder wall thickening. So here you see the thickening. The normal was less than 3 centimeters, as you remember. This looks to be thickened here. You also are likely to see paracholecystic fluid. So we see it here in this image, as well as in this image. We see it here, as well as the wall thickening. Less specific findings, you may have some gallbladder distension or sludge. A very key point, though, whenever you're looking at a patient ultrasound, is to try to find the obstructing stone. So in this image here, it looks like this is our culprit lesion here. And then as we look into the structure, the ultrasound on the right, we do see the anechoic gallbladder here. As well, we have some shadowing coming from these hyperechoic structures here, likely gallstones. And then we do see a structure here that's on the neck and maybe even almost protruding into the cystic duct. That is our culprit gallstone. So this is likely the reason for the acute cholecystitis. Complications, there are many. The most common being gangrenous cholecystitis. So this is where you have some intraluminal membranes that you can see on ultrasound, as we see here. Asymmetric wall thickening, which is also represented in this image. I know this isn't the best quality, but we see some thickening here where it's kind of spared around here. And then we may have some focal perfusion defects on Doppler. And an interesting finding is you may see an absence of sonographic Murphy sign. So this is whenever you're going to press, you look at the patient's gallbladder with the ultrasound probe, and you press on the area right over the gallbladder. And you typically have severe pain, and you may see with patients inspiration, they may have inspiration arrest. So this may be absent due to the ischemic denervation of the gallbladder itself. Other complications, perforation, emphysematous, cholecystitis, pericholecystic abscess, and many more. So the next topic here is gallbladder polyps. So these are outgrowths of the gallbladder mucosal wall. It's been observed in about 4.5% of gallbladders assessed by ultrasound and about 14% of resected gallbladders. Typically, these are incidental findings, but some patients may have episodic right upper quadrant pain. Most lesions are not neoplastic, but are hyperplastic and represent cholesterolosis, which is lipid deposits. So some risk factors for malignancy: if you have a polyp greater than 1 centimeter, which the incidence of a malignancy is about 40 to 77%. Sessile polyps, age greater than 50, and Indian ethnicity. So here we have a couple of images that we would see on ultrasound. So ultrasound itself is about 84% sensitive and 86 or 96% specific for detection of gallbladder polyps. So we will see some differences within the size as far as their echogenicity. So smaller tends to be more echogenic, as we're seeing here. Smaller are usually smooth and adherent to the wall, as we're also demonstrating here in this top image. As the larger polyps, they tend to become more pedunculated, as we are also demonstrating down here on this bottom image, and may have a more granular outline. One important distinguishing feature when you're looking at this patient is, whenever you're going through and you see one of these lesions, you're like, okay, well, I think we're dealing with a stone. One thing that might be helpful when you're going through this is to look for shadowing. As you see, we do not have any shadowing here that we would typically see with gallstones themselves. And these lesions are typically immobile. So if you have the patients move positions, you're not going to see the rolling stone sign that you would see with gallstones as well. You may have some mobility if they're pedunculated, as is this structure here. So going through this, we are using a curvilinear probe, medical orientation. We see the hyperechoic wall here. We do see a isoechoic structure to a hyperechoic structure within the wall here. And so this is our polyp. As we see here, another polyp that's pedunculated. Another topic here that we're going to go through is adenomyomatosis. So this is an abnormality of the gallbladder characterized by overgrowth of the mucosa, intramural diverticula lined with mucosal epithelium. This is the Rutkansky-Aschoff sinuses, and thickening of the muscle wall. This is a relatively common and benign cause of diffuse gallbladder wall thickening. Your typical clinical presentation is somebody that comes in completely asymptomatic, but you may see this with chronic biliary inflammation. There's 3 different distributions that you might see with adenomyomatosis. So diffuse, so you see thickening and irregularity of the mucosal surface and the mucosal coat, leading to cystic-like structures in the gallbladder wall. You may have segmental, so circumferential rings that divide the gallbladder into separate interconnected departments, and a localized or fundal, so these are cystic structures that form a nodule, typically in the fundus, that project into the lumen, giving an appearance of an polyp on ultrasound. So here we see diffuse, as illustrated in our cartoon here, segmental, and then we see localized here, or fundal. So what we're going to see on ultrasound is just mural thickening, as we see in each of these here. And segmental is especially important because it's very difficult to distinguish from gallbladder cancer. So one important finding that we do see on ultrasound that is highly specific for adenomyomatosis is something called the Comet-Tail artifact. So echogenic intramural foci, which emanate a V-shaped comet-tail reverberation. So we see that here in our image. Right here we have a curvilinear probe. Looks like we're in a medical orientation. It's cut off here, but I know this. We have the isocholic liver here. We do see the gallbladder wall. We do see some thickening here. And then we do have this V-shaped structure representing our comet-tail artifact. So this is actually representing the cholesterol crystals within the lumen of the Rokitansky-Aschoff sinuses. This is very highly specific for adenomyomatosis. Another topic here is gallbladder carcinoma. So this is typically or relatively uncommon. It is the 5th most common malignancy of the GI tract. Predominantly affects elderly patients greater than 60 years old. It does have a 4-to-1 female to male distribution, and it is seen with long-standing cholestystolithiasis. Unfortunately, patients are typically asymptomatic until late in their diagnosis, where they miss that therapeutic window, or they may have been able to have resection. Jaundice is typically often the first presentation. They also may present with anorexia, right upper quadrant pain, and weight loss. So on an ultrasound with gallbladder adenocarcinoma, you may see an intraluminal mass, diffuse wall thickening, as represented here. We do see also the intramural mass, and then a large mass basically completely replacing the gallbladder. This one is almost, this is a pretty large mass here. These are also very heterogenic as far as their echogenicity. They may be more hypoechoic as well as we are seeing here in this image. And you typically will see some gallstones present in most of these cases, 60 to 90%. So as we go through some cases here, I want to also just show you exactly what we should be doing as we're going through them. So we should be identifying what probe we're using. We should look at the orientation. We should comment on the quality of the image, the echogenicity, the artifacts, and then give our final interpretation of the image. So case number 1, during routine POCUS training, you take turns with a colleague scanning each other. While scanning, you see this. So as we look at this image, we want to make a comment on the probe type. So we have a curvilinear probe here. I know this because of the curved structure here that we're seeing, as well as the image we're getting out from the sides. We are in a medical orientation as we have the probe marker to the left of our image here. As we're going through, we also want to comment on the quality of the image itself. So in this image, it looks like it's a pretty good quality image. We do see the different echogenicities here. I think our depth is good, our gain is good as well. So here we do see a hyperechoic structure here, as well as we see some hyperechoic rims within the wall here, and it's hard to really make out the rest of the structure, as there seems to be shadowing cast on this entire structure here. So knowing that you were doing the exam and you used the X-7 technique when you were examining this patient, you know that this is the gallbladder. And so this is an interesting finding, actually. So this is representing multiple gallstones lining the gallbladder. So this is something called the west side, actually. So this is wall echo shadowing. So this is a stone-filled gallbladder completely obscuring the lumen. So as we go through, so we noticed that it was a curvilinear probe, medical orientation, good quality image. We saw the hyperechoic rim on the structures here, and then we saw the posterior acoustic, this should say shadowing, obliterating the gallbladder wall in the view of the gallbladder completely. So this is gallstones. Case number 2. So we have a 44-year-old female G2P2 with a history of hypertension, obesity, hyperlipidemia, who presents with acute right upper quadrant pain associated with pain in the right shoulder and has had subjective fevers. You do a right upper quadrant ultrasound, and this is what you're seeing when you're imaging the patient. So we're using a curvilinear probe here. This is a medical orientation. It looks like we do have a pretty good quality image. Our gain seems to be fair, as well as the depth that we are getting on the image. We do see to the left of the screen here, we have an isoechoic structure. We do see a hyperechoic structure rim here and an anechoic structure here. We do have some shadowing noticed throughout the structure here. We can identify some vessels here as structures. So it does seem that we have an anechoic structure here lined by a hyperechoic ring, and then we do see a couple of anechoic structures above. So also commenting, we do have a hyperechoic structure here, as well as some within here. So from this image, we do have the gallbladder in view here. We do see some wall thickness here, as well as maybe some pericholecystic fluid lining. We do see some hyperechoic structures likely representing stones, and we do have a pretty significant stone here, which is likely causing our patient acute cholecystitis, acute calculus cholecystitis. Important to note that we do have in the image here the portal triad. So we see here the portal vein, we have the CBD and the hepatic artery. So as we went through, we have the curvilinear probe, medical orientation, good quality isoechoic liver, anechoic gallbladder with thickened hyperechoic wall, and we have some anechoic, hypoechoic within, hyperechoic structures within the lumen with some posterior acoustic shadowing. This is acute cholecystitis. And then case number 3. So we have a 44-year-old male with hypertension presenting to the clinic for routine follow-up. Given this patient was pretty healthy, you just renewed his lisinopril, you thought, we got some extra time. Let's just take a look at what your gallbladder looks like. So you practice your ultrasound skills, and this is what you get in your image. So I think we are using here a curvilinear probe. We are in the medical orientation. We do see that this is a pretty good quality image. We have good depth, as well as our gain seems to be good as well. We are seeing here in the left side, we have a isoechoic structure here, likely representing the liver, and a anechoic structure here with hyperechoic rim. And then we do see this lesion here. Notice it seems to be adherent to the wall, seems to be more hypoechoic. Adherent to the wall, it doesn't seem to have any shadowing casting down here. And then we see the portal vein here to the left. So this is actually a gallbladder polyp. So as we went through curvilinear probe, medical orientation, good quality image, isoechoic liver, anechoic portal vein, and gallbladder, and then we see the echogenic structure abutting the wall here without the shadowing. So this is a gallbladder polyp. This is 4 millimeters. So really important when you're looking at these. This is a patient that you just decided to do this image on just because you had some free time. So we need to know, when should this patient follow up? So there's pretty good criteria as to when to follow up these. So for a completely asymptomatic patient, polyps that are greater than 2 centimeters are usually malignant. You need an extended cholecystectomy with lymph node dissection and partial hepatic resection in the gallbladder bladder. For a polyp that's 1 to 2 centimeters, this is possibly malignant, and it's a laparoscopic cholecystectomy is indicated. For polyps that are 0.6 to 0.9, if you have risk factors as we identified previously, then cholecystectomy would be warranted. Without those risk factors, a repeat ultrasound every 6 months for 1 year, and then if it is stable, then annually. And then for our gentleman here, for polyp less than 0.5 centimeters, with risk factors, repeat in 6 months. If stable, then annually. And then for him specifically, without risk factors, we're going to repeat his ultrasound at least once in a year. So key points from this slide deck. It's important to understand the anatomy to be able to identify structures. Also very important to recognize normal. It's very important to ultrasound as many patients as possible, so that way you may see variant anatomy as well as normal. There's multiple ways to obtain proper imaging. So if you're having a difficult time with one of the techniques that we used above, then you may want to try a different technique, or maybe just a different probe. And then there's multiple positions that you could put the patient in. So you could have them supine or in the left lateral decubitus position, and you can improve the quality of your image. And it may help with your differential as well as you move the patient. POCUS of the gallbladder is a quick, safe way to identify many gallbladder pathologies. And understanding artifacts and using them to help identify structures and pathology is very important. Thank you.